coming up.
You know, when we look at the patients, a couple of whom you described, we're really not offering them any other therapy other than opioid therapy. Is it not that fair then to say that we're providing these folks with palliative care?
The expert task force was unanimous in recommending that we scale up safer supply, that we scale up, that we stop criminalizing people who use substances, ramp up treatment on demand.
Because it's a failed experiment. We've heard that over and over and over here. We know it's a failed experiment. The BC government knows it's a failed experiment. And the question that I have is when will the NDP Liberal government know it's a failed experiment?
Point of order from Mr. Johns.
Point of order, just for clarification, the BC government has not asked to stop decriminalization in British Columbia.
Thank you.
Perhaps is ideologically motivated by his wacko comments. So that being said,
point of order, Mr. Chair, it is completely unacceptable for a member to be calling another member wacko.
Mr. Johns, please contain yourself. He said that your comments were wacko, which may be unpleasant to hear, but it wasn't an attack on you.
This Guy's Garage. Like and subscribe.
you know, when we look at the patients, a couple of whom you described, we're really not offering them any other therapy other than opioid therapy. Perhaps other things in addition to it, but just for the sake of those listening at home, we all know that people who take opioids will eventually get habituated or used to the dose they're on, requiring escalating doses. And if that's the kind of medicine that we're going to provide, is it not that fair then to say that we're providing these folks with palliative care?
Mr. Chair, thank you for that question. Absolutely, that is one of the significant problems with opioids, is as you take them, your brain has changes in your neurochemicals that what you're taking, your brain becomes used to, and that becomes your normal. So to get the same effect, you have to increase the dose that you're taking. So to get the same euphoria, you have to continue to increase the dose. But perhaps even more importantly, when your brain readapts to this new level of that's your normal, you have to be taking opioids. You have to be taking them. And if you miss them, then your brain will miss them, and you go into what's called withdrawal. And withdrawal is a horrific experience where you get severe pain, anxiety, nausea, vomiting, diarrhea. You can feel literally like you're going to die. And then you keep thinking you need more and you need a higher dose. So whenever you're in a scenario where you're taking an opioid regularly, you're always chasing the high. Your dose continues to escalate. And you're always trying to medicate away from the withdrawal. And an important thing that isn't always mentioned that I want to add is that as your brain regulates and gets used to a certain amount of opioids, that's generally you tolerate that if you are well. If you develop a pneumonia, an endocarditis, or any other illness that affects your cardiorespiratory system, that same dose can be toxic or fatal. So when you're taking an opioid, you could be taking the same dose. You could be taking the same dose of your Dilaudid or your fentanyl. And if you develop a pneumonia, a sepsis, you will actually could become toxic from the same dose because your brain wants more than what your body can now tolerate. So when you are in a position of getting a treatment that's given to you daily to keep you going from one chasing withdrawal to another, it's not allowing your brain an opportunity for recovery. You are staying in a cycle in which you are absolutely dependent on the medication and can be at risk of developing tolerance, needing a higher dose, and needing a dose that eventually will be more than you can handle. And from the cases that I mentioned in hospital, patients were being prescribed substantially more than they could actually tolerate when we had them in a position where we could see what they were taking. And had we given them the amount that they were prescribed, it would have been fatal for them.
Thank you very much for that, Dr. Koivu. And through you, Chair, it's interesting that you started talking about dosages. So when we looked at patient one, I wrote this down, they had 900 milligrams of morphine and 320 milligrams of hydromorphone. Using an opioid calculator to kind of look at the overall dose of milligrams of morphine, that would be about 2,500 milligram morphine equivalents. Is that correct?
That is correct.
Thank you for that. And through you, Chair, again, looking at that for the average Canadian, again, doing the math, that's about 640 Tylenol 3. You don't have to trust me on that, but I used the same calculator to do it. And the reason I talk a bit about this is people often think, well, it's one tablet of 8 milligrams of Dilaudid. And I think that it's a bit concerning that for those who don't use opioids on a regular basis, that even though it's one tablet, it is still a significant amount of opioid. And maybe, Dr. Koivu, you could talk a bit about that.
Absolutely. One tablet is also equivalent to 4 Percocet or 20 milligrams of OxyContin. Those are doses that we considered fairly high during the opioid crisis. And taking 2 of them is essentially the amount that we would be considering would be, I don't know, more like what an amount that would be considered a relatively safe amount for most people. 1 even can be considered toxic if you're not used to taking it. So when we're looking at the numbers that we're seeing, they're substantially higher than the milligrams of equivalent of morphine that I was seeing during the time when people were prescribing heavily for chronic pain. These are the highest doses I've ever seen.
And through you, Chair, very quickly, Dr. Koivu, if we talked about 2,500 milligram morphine equivalents, what would be the recommended amount, say that we would, a prescriber should really be very cautious in going over? And I realize this is a different patient population even than a usual chronic pain population, but what would be a guideline for just for Canadians listening out there?
Is 100 milligrams of morphine equivalent per day or less.
And these people are receiving up to 2,500.
Thank you.
Or more.
Or more. Thank you.
Thank you. In terms, I'm going to go to Ms. Hopkins, and you are co-chair on the expert task force on substance use, and the expert task force was unanimous in recommending that we scale up safer supply, that we scale up, that we stop criminalizing people who use substances, ramp up treatment on demand, recovery prevention, and education, and you had a wide. A really wide spectrum on the expert task force on substance use. Can you speak about maybe your disappointment about the government not following through with the recommendations and just your experience about how important it would be to reinstate the expert task force and to implement those recommendations?
Yeah, we're talking about using evidence, and the question is about whose evidence is more credible. That's quite a common conversation when it comes to First Nations people whose worldview and culture-based evidence is typically set aside. But that does not mean that, for example, culture and safe supply are like completely incompatible. Safer supply is one tool, one more tool in the toolbox. There is no silver bullet. There is not one medication. There is not one strategy, method, or form of care that will solve the opioid crisis or the toxic drug supply. There are many, many strategies that have to be used together in combination.
I don't know if the question was heard properly, and I apologize for that. I just, in terms of like we just heard from the First Nations Leadership Council and the BC First Nations Justice Council, and they're calling for an emergency cross-governmental and multilateral strategy that ensures the safety of people who use drugs. And Dr. Sayers, a BC FNJC council member, says the toxic drug crisis needs to be treated and addressed as a public health issue, not a criminal justice issue. And
Yes.
Chief Grant Stewart also said it's very much wrapped in the destructive impacts of colonialism, right now, how we're proceeding. Can you maybe add to your thoughts on those statements?
Yeah, I just want to emphasize the importance of safer supply, that's one tool that needs to be available to everybody. In addition to understanding the context of First Nations people, as I said earlier, we do not have community-based resources necessary to address the impacts of opioid toxicity or the toxic drug supply. We don't have services close to home where people need them when they need them. And that often leads them to, moving, traveling off reserve for periods of time. And often the crowd that they most find welcoming are crowds that are involved in selling illicit drugs. That comes back into community. And now we create a new relationship that has significant impact on families and on the whole community. For the first time ever, First Nations communities are reporting murders in their community, not by First Nations people murdering First Nations people. It's by gangs coming from large urban environments onto reserve and committing these crimes. Gun violence, human trafficking has increased. And if we look at, what is the perception of that? We could say, well, there are, because of racism in Canada, First Nations people will be blamed for those kinds of activities. They did this to themselves. But that's the same sentiment of people who use drugs. They should just stop. They can just decide. Why don't they choose something different when they're losing all these things? We're blaming the victim without supporting their right to health and social services. The United Nations, sorry.
Thank you, Dr. Hopkins. Ms.
stop
Goodrich,
there.
please, for 5 minutes.
Dr. Pauly, did the study you cited look at diversion as an issue?
Yeah, thank you. That's such an important question because that is definitely an issue that is, I would say, creating the most controversy. So I will speak to two ways in which, while the study didn't directly look at diversion.
Okay, so it didn't look at diversion.
No, I will explain.
Yes or no? We've got a
study-
very limited amount of time, and I asked a very short question, and the convention in this committee is that typically witnesses answer for about the same amount of time that the question took. So did diversion get looked at?
Diversion was not apparent because there was a dose-response relationship. In other words, if people got more days of the medication, there was less risk of overdose, which suggests they were taking their medications, and there was a dose sensitivity relationship, higher doses, less risk.
Thank you.
So what this leads to is that people were taking their meds in many cases.
To Dr. Koivu, I'm sure you've seen the proposals that are coming out from the City of Toronto asking for a proposal to move towards a decriminalization for that city. Do you think that would have impacts on communities like London?
I think that anything that happens in Toronto is definitely going to have impact on London. And what we're seeing in London itself has been largely affected, I think, by decriminalization as it is. We're certainly seeing a lot more open drug use, a lot more, very common to see people injecting in parks and smoking fentanyl in parks and injecting Dilaudid in public spaces already. So I would think that would be something that we would have a problem with, yes.
Thank you. So really quickly, have you seen a change in the drug deaths in London since the so-called Safer Supply program came in?
Absolutely. I don't know how to answer that really quickly, but the first thing I'll say is in 2016, our overdose deaths were equal to the province. Since 2016, in 2022, where I have information, the provincial rates went up by about 2.7. London's went up by almost fourfold, so a significant increase in overdose deaths compared to the provincial average, and a significant increase in overdose deaths compared to the other community I work in, which is just south of there, which had exactly the same in 2016 and now continues to have the same as the provincial average. The other place where I see significant changes is in youth. If you look at the youth population, and this data is all available on the Public Health Ontario's opioid tool, that people 15 to 24, London's was lower than the provincial average in 2016. Now it's substantially higher, same with people 25 to 44. So when I'm looking at people that I would consider young, that there has certainly been an increase in deaths. The thing about Ontario often, also the other thing is hydromorphone is absolutely more common, over twice as common to find hydromorphone in deaths in London than the provincial average. Often the provincial averages dilute things, and if you go to Ontario, you can actually look and find that where safer supply has been available, there are increases over provincial averages.
Thank you. I appreciate that. And now I'm going to move a motion that I put on notice on Friday, Mr. Chair, and it's that the committee invite the Minister of Mental Health and Addiction and the Associate Minister of Health before the committee for no less than 2 hours, and that the study of the opioid epidemic and toxic drug crisis in Canada be extended by 6 meetings to invite further witnesses. I do understand that we've perhaps had some conversations about having some amendments, and with that, I will cede the conversation.
Thank you, Ms. Goodridge. The motion is in order. The debate's on the motion. Dr. Ellis has the floor.
Thank you very much, Chair, and I appreciate the comments from my colleague and the need to continue this discussion. And I think it's important for Canadians that we underline the fact that there is some controversy that exists here, not all of it based in science, much of it based in opinion, which is not necessarily helpful in an argument in where we do know there is good scientific arguments based, which many of my colleagues may not like the fact that it does exist, but it does exist. And also, I think it's important to continue on this road to enable this committee to understand that some of the science that has been referenced here does not answer the questions that we need answers to. I think it's also important that we understand that the government of British Columbia has asked for an end to the decriminalization experiment, certainly outlined by communities such as New Westminster, Richmond, Campbell River, Kamloops, Sicamous, and that as Canadians hear more and more about the experiment that has been undergoing here, Canadians are fearful for their own communities. They're fearful for their communities because of contamination from used paraphernalia. They are concerned because of the potential for exposure to drugs by children. We've heard even by pets in some areas. And the other thing that I've heard directly from Canadians is that they are concerned due to the loss of accessibility of their downtowns. And that is also a concern that we heard very clearly from the Deputy Chief of Vancouver, who testified at this committee not that long ago, who made it very clear that the decriminalization experiment has led to loss of downtowns and use of substances outside of businesses, outside of residences, on transit, near schools, parks, beaches, etc. And the Deputy Chief's testimony really related to the fact that police were powerless to stop this type of activity. So we also know that the Minister of Mental Health and Addictions has spoke very forcefully about this in the House of Commons and in the media, attempting to explain away the request by the government of British Columbia to end the experiment. And I find it interesting because it was the government of British Columbia that came to the federal government asking for the experiment, understood that. But we all know, even though this is not scientific in a sense, but when an experiment is going awry and the the people in charge of the experiment say we need to end it, then it needs to end. And when you are doing a scientific experiment such as a randomized controlled trial, when those lead investigators understand that something has gone awry, they don't continue the experiment. They stop it. And they don't wait for days and days and days to stop it. They stop it immediately when there are those signals out there. And I'm very, very disappointed in the NDP Liberal government, and specifically in the Minister of Mental Health and Addictions, that the British Columbia government has asked for the experiment to end, and now there are negotiations with the NDP Liberal government to continue the experiment, which again, if we want to talk about this, even though I realize it's not scientific, but if we want to use that metaphor, then we know clearly that the experiment must end now for the betterment of this country. Because it's a failed experiment. We've heard that over and over and over here. We know it's a failed experiment. The BC government knows it's a failed experiment. And the question that I have is, when will the NDP Liberal government know it's a failed experiment?
Point of order from Mr. Johns.
Point of order, just for clarification, the BC government has not asked to stop decriminalization in British Columbia.
Thank you.
They have made
Mr.
Point of order.
some
Thank you very
changes,
much.
and I just want
point of order.
also,
It's a question
Mr.
of
Chair, I think it's been
debate, so
well
I'm gonna cut
So when
you off
my
there, Mr.
colleague-
Johns.
It's been
Dr.
ruled
Thank you
by
very
the
much, Chair.
Chair.
So when my colleague wants to have the floor, he can raise his hand and have his turn. He should know that. He's been here long enough, even though that he perhaps is ideologically motivated by his wacko comments. Then we
Seriously?
need to continue on with
Mr.
this.
Chair?
So
Mr.
that
Chair,
being
point
said,
of order. Point of order. Mr. Chair, it is completely unacceptable for a member to be calling another member wacko, and that is completely unacceptable. You know,
Mr. Johns, please contain yourself. He said that your comments were wacko, which may be unpleasant to hear, but it wasn't an attack on you. And your interruptions do not constitute points of order. I would ask that you wait your turn. You are on the speaker's list. You're third. Dr. Ellis, go ahead.
Thank you very much for that, Chair. And, you know, I don't mean to disparage the member. As I said, his comments are wacko. And I think it important to understand that the citizens of this country are no longer wanting to tolerate ongoing difficulties with the experiment, as it has been termed by my friend and colleague, Dr. Handley from the Liberals, as the experiment from the outset, which was part of the motion of this study here in Health Committee. I'll end my comments there. Thank you, Chair.
Thank you, Mr. Viss. Mr. Johns, please.
the only shovel that's gone in the ground is a ceremonial one 3 years ago. And people are waiting. They're waiting up to 6 months to get help in certain parts of Alberta, Mr. Chair, and that's if they want help. But the goal should be to keep people alive. Harm reduction and treatment and recovery go hand in hand. We don't need to have one without the other. This is a crisis that is ravaging North America, and it is skyrocketing in conservative provinces and Republican states. And we need to change direction. We need to work collectively. And I'll say this, Mr. Chair, that in Portugal, the politicians, where they were successful, is they got out of the way and they let the experts lead with evidence-based policy, evidence-generated policy, peer-reviewed research. That's how they moved forward. And I don't think of another health issue where politicians are having their say like this and interfering with what is truly a health issue. And so that's I support going to 2 meetings, Mr. Chair. And I also wanted to make sure that my comments are on record.
There, thank you, Mr. Johns. Dr. Pawlowski, please.
I would dearly like to get back to the expert witnesses we've invited here and not listen to other MPs wax on about their views on this subject. I was certainly tempted to put a motion to adjourn debate, but I won't. But I would suggest, please, can we not all decide to vote on this? There seems to be unanimity. Let's vote and let's get back to the witnesses. We are doing a study on this subject. We invited these people here to ask their opinion, and I'd like to get their opinions. Thanks.
Ready for the question. So the question is on the amendment. And so just to be specific, the amendment is to delete all of the words in the motion, or to delete the following words from the motion. That the committee invites the Minister of Mental Health and Addictions and Associate Minister of Health before the committee for no less than 2 hours, and also to change the word 6 to 2. So the impact of the amendment would be that the following: that the study of the opioid epidemic and toxic drug crisis in Canada be extended by 2 meetings to invite further witnesses. Does everyone understand the question? So all those in favor of the amendment, raise your hand. It's unanimous. The amendment is adopted. Now we're on to the main motion. Any discussion on the main motion? Seeing none, all those in favor of the motion as amended, raise your hands. Opposed? The motion is adopted unanimously.
More people are dying in British Columbia despite both safe supply and decriminalization. Why do you think that is?
They're dying because 85% of deaths are caused by a toxic, unregulated drug market, and we haven't adequately scaled up interventions like harm reduction and treatment, because it's a combination of those that will reverse the trend.
Do you believe recovery from addiction is possible?
I believe recovery is absolutely possible, and recovery is an individual journey. There are many pathways to recovery.
Dr. Pauly, sorry for putting you on the spot here, but help the committee out, because you've said in response to Dr. Theriault, who said that the experts seem to come to different opinions as to the evidence for safe supply, and you said, well, you did a peer review and seemed to pretty overwhelmingly show the benefits of safe supply. But let me just point out what else other committees heard. So we asked Health Canada to come and appear before the committee to begin with, and we had the experts that I think were the ones behind approving BC's request and seemed to be in favor of safe supply. They themselves admitted that there wasn't very good evidence for the benefits of safe supply. I would note the BC health officer in a review of prescribed safer supply says, and I'm quoting, most of the limited publisher peer-reviewed studies lack a control of comparison group, and the actual intervention received by study participants is in most cases a combination of broader access to wraparound health services, including safe supply, primary care, making it difficult to attribute any benefit to PSS alone. They suggest that they need to have more studies. The Stanford Lancet Commission that looked at the opioid crisis, and I would point out these aren't a bunch of right-wing fanatics. They, and here I'm quoting from the actual study, they say...
Dr. Pelosi, could you drop the arm of your microphone down closer to your mouth there? Yeah.
How's that? Is that
Thank
better?
You.
So again, I'm quoting from the Stanford Lancet study. They say, and I'm quoting, evidence clearly shows the folly of assuming that population health inherently improves when healthcare systems provide as many opioids as possible with as few possible regulatory constraints as possible. They too were against safe supply. We talked to the head of that, and he said, well, the problem with safe supply is basically you're replicating what caused the problem to begin with, which was us doctors prescribing too many narcotics. People get on narcotics, and then they have trouble getting off of it. So do you continue, though, to say, no, the evidence is clear that the safe supply is good? So.
Yeah, I really appreciate that question about the science, because it has been very confusing and disturbing to see the way that some of the debates have played out. And I'll just begin with the fact that in 2020, many of the citations that you provided preceded or were in the very early days of the development of the body of evidence on safer supply. In fact, since 2020, it's like doubled. And in fact, some of the strongest evidence has emerged in about the last 6 to 12 months. And, you know, our team obviously is in the forefront of producing evidence in British Columbia, where we are seeing positive impacts. So yes, I stand by my statement in the review of over 40 studies. The findings were overwhelmingly positive. And what I really want to urge this committee is to separate ideology from evidence and recognize, I don't think there's any of my colleagues who wouldn't say we need more treatment as well. And yet, we know there are still challenges with treatment. People, you know, they come out of treatment and they, you know, they do relapse as well. So we need to look at what kind of comprehensive system we're creating instead of creating, you know, these ongoing kinds of tensions. And I'll just stop there in case you have a follow-up.
Thank you. And while I would just continue to say that BC Health Officer's report is quite recent, as is Health Canada, and certainly looking at the evidence, I certainly wasn't overwhelmed with it, but let's change the subject. Now, with your study, it wasn't a randomized control trial, right, which is the gold standard. And certainly the validity of your results, I think, depends on how well you matched the people getting safe supply and those who weren't getting safe supply. One of my concerns with your study, and you can correct me if I'm wrong, the comparison group, the people who weren't in safe supply, you got those names from various places, one of them being the discharge abstract database, which in my understanding is from hospital records on people who'd been admitted with either a diagnosis, something to do with using opioids, right? Certainly my concern would be, well, you have a whole bunch. In your comparison group, you have a sicker population than you do because they've been in the hospital recently, either because they overdosed.
You're out of time. If you could just get to a question, we get a short answer.
Well, I guess she's heard my question, and I guess I get no response to her answer. But am I wrong?
As succinctly as possible, Doctor.
Answer? Okay, thank you. So in terms of our study, it came out after the Provincial Health Officer's report, as did a number of other studies. The control group, there are multiple linked databases which were used to generate through two different methods. The control group matching on multiple different variables. And I'd be happy to refer you to Dr. Baudin's seminar, which explains this extremely well in terms of how the matching occurred and the similarity between the two groups. So thank you.
Thank you, Dr. Paul.